Okay. All right. Now we're going to talk about a subject that certainly is near and dear to my heart, pardon the pun, but cardiac emergencies. As a review of the cardiovascular system, we know that blood enters the heart through the superior and inferior vena cava and comes into the right atrium, goes into the right ventricle, which pumps the blood then to the lungs for the exchange of gas. It comes back into the left atrium, where it's pumped into the left ventricle, and then pumped out to all parts of the body. The heart has its own electrical conductive system, and it includes the SA node, the sinoatrial node, which is located up in the right atrium. That's the primary pacemaker for the heart. It initiates an electrical spark that travels through the atrium, causing both atrium to contract. The spark is then held up at the AV node, and the AV node is the gatekeeper to the ventricles. It holds onto that electricity just for a split second, no more than 0.2 of 1 second, and then lets it down through the bundle of His and through the left and right bundle, through the Purkinje system, which causes both ventricles to contract. So both atrium contract and both ventricles contract at the same time. We'll also discuss the composition of blood and why blood is so important. I mean, obviously, it's necessary to perfuse or provide nutrients and oxygen to all our cells. We'll also look at the flow of blood through arteries, veins, arterioles, venules, and capillaries, and how it flows in one direction, leaving the aorta of off the left ventricle into smaller arteries, into smaller arterioles, into capillary beds, and from capillary beds to venules, into veins, and then ending up back in the heart through the superior inferior vena cava. Now, in order for blood to be oxygenated, it has to pass through the lungs. I had mentioned that all blood returns to the heart through the superior vena cava to the right side of the heart, where it's pumped to the lungs, where gas exchange takes place. It leaves the right ventricle through the pulmonary arteries, the only place in the body where arteries carry unoxygenated blood. Once in the lungs, the blood is oxygenated and returns through the pulmonary veins, the only place in the body where veins carry freshly oxygenated blood, and enters into the left side of the heart through the left atrium. We'll look at how the heart must function, and by functioning effectively as a pump, how it causes a blood pressure. We'll also talk about shock. And shock is a state of hypoperfusion where you're not getting a good blood supply to all your tissues. So here's a diagram of a cross-section of the heart, and you can see that in the heart, blood enters through the superior and the inferior vena cava into that right atrium. Blood then goes through the tricuspid valve into the right ventricle. The right ventricle pumps blood out of the pulmonary arteries to the lungs. Blood then comes back through the pulmonary veins into the left atrium, where it then passes through the mitral valve into the left ventricle, where it then is pumped out the aorta to all parts of the body. So this particular diagram just shows you the flow of blood through the heart that I just described. Now, an acute coronary syndrome is, if we break that down, acute means sudden, coronary means heart-related syndrome, a set of signs or symptoms that would lead you to believe that what you're seeing is heart-related. So an acute coronary syndrome refers to any time the heart may not be getting enough oxygen. And there are several different kinds of problems. It says many, but there's only a few different kinds of problems that fall under the acute coronary syndrome heading. Acute coronary syndromes include heart attacks, which are caused by a either completely occluded coronary artery or a partially occluded coronary artery. Acute coronary syndromes include angina or angina pectoris, which literally means chest pain, which is caused by narrowed coronary arteries. They may be 40% narrowed, 50% narrowed, 70% narrowed, and because they're narrowed, they don't provide a good blood supply to the heart muscle. And when you work it hard, the muscle doesn't get a good blood supply because of the narrowed arteries, causing chest pain. And then there is unstable angina, and we'll talk about that as well. In any event, we want to treat all patients with acute coronary syndromes as if they're having a heart attack. Because we don't know. As an EMT, you're not going to know whether or not this person's having a heart attack, but you will be able to know based on your assessment whether or not the description of their pain is heart-related or not. Chest pain is the best known symptom of an acute coronary syndrome, but it often isn't described as pain at all. It's often described as a crushing or a dull or heavy or squeezing ache in the chest, like an elephant is sitting on their chest. The pain or the discomfort may radiate to the jaw, to the neck, down the arms. And the purpose of that, or certainly the reason that that occurs, is that the same nerve plexus that serves the heart also serves the neck, the jaw, and the left arm. So the brain doesn't really know where the discomfort is, so you feel like the discomfort is in those areas as well. Now, dyspnea or difficulty breathing is also found in patients with acute coronary syndromes, especially if that left ventricle isn't functioning properly because there's a heart attack occurring. Remember, the left ventricle gets its blood supply from the lungs. So if the left ventricle fails because of a heart attack in that area of the heart, then blood is going to back up into the lungs, causing acute pulmonary edema, which may cause the patient to not oxygenate well if there's water in the alveoli, and that would lead to that feeling of difficulty breathing. Now, in some patients who are diabetics, patients who are over the age of 70, postmenopausal women, when they're having their acute coronary syndrome or their heart attack, dyspnea may be their only finding or their only complaint. Other symptoms of an acute coronary syndrome include anxiety, the feeling of impending doom. They may feel sick to their stomach. They may have a sudden onset of sweating. Their pulse may be very fast or very slow, and it may affect their blood pressure as well. Oftentimes, in some patients, an acute coronary syndrome, those diabetics, those patients over 70, those postmenopausal women, they'll have the sudden onset of flu-like symptoms, the nausea, the discomfort in the abdomen, sweating, feeling weak, anxious, and that's the only symptoms they have that would lead us to believe that what they're dealing with is heart-related. So when you're assessing a patient with an acute coronary syndrome, in other words, you get an ambulance call and you arrive and the patient is complaining of chest pain, you want to do your primary assessment like you do with all patients. In other words, make sure that there are no life threats. Make sure that their airway is open and maintainable. Make sure that their breathing is adequate. Make sure that they're not bleeding to death and that they have a pulse. And if there are no immediate threats to life, you can obtain a good history and do a physical exam. Now, to get a good history, we've been taught sample, and we've also been taught OPQRST. OPQRST works really well when we're trying to get a history of pain. O stands for onset. You know, what were you doing that brought the discomfort on? And oftentimes, heart attack pain occurs at rest. So, you know, certainly if they're shoveling heavy snow or carrying the weights up to the attic, that may cause heart-related chest discomfort. P is provocation. Does anything make it better or worse? You know, this chest discomfort is caused by a narrowed or completely occluded coronary artery, and so oftentimes nothing makes the pain better or worse. They describe it as constant. It isn't made worse when you take a deep breath. It isn't made worse when you push on their chest. Now, Q is quality, and what we want to know here is their description of what it feels like. If we say to the patient, is your pain sharp or dull? Well, we've just only given them two choices. We've only given them the choice of sharp or the choice of dull. And if neither of those is the reason that they're, or if neither of those actually describes the way they feel, they may give you a wrong description. R is radiation. Does it go anywhere? And again, we would expect heart-related chest discomfort to radiate to the neck, the jaw, and down the left arm. S is severity on a 0 to 10 scale, with 0 being no pain and 10 being the worst they've ever felt. Have them give you a number if they can. If they can give you a number, you know where they're at right now. And then if you provide oxygen, you would expect the pain to get better. If the patient carried their own nitroglycerin and you assisted them administering it, you would expect the pain to get better. T is time. How long have they had the pain? It's really important to find out how long they've had it, because around here, we're 120 minutes in any one direction from a cath lab. Now, if you're in Council Bluffs, obviously you have a cath lab right in Council Bluffs. So if you're far away from a cath lab, greater than 60 minutes, then this patient might be a candidate to receive a clot-busting drug. You want to obtain a past medical history using sample, and you want to get a good set of baseline vitals to drive your decision. You want to place the patient in a position that certainly is most comfortable for them, and that would be sitting upright. You can determine if oxygen should be administered based on their complaint of shortness of breath, their skin color, their pulse oximetry, if it's reliable, and then consider transport. If you're capable, in other words, if you have the equipment, you can obtain a 12-lead ECG. As an EMT, it is within your scope of practice in Iowa to obtain a 12-lead ECG. You wouldn't be able to interpret it, but you certainly would be able to obtain it and perhaps send it on, or at least hand it to the ED staff or the paramedics when they arrive. If the patient has their own nitroglycerin, and they are having chest pain, and they have a history of needing nitroglycerin, in other words, it is prescribed to them, and they have it with them, then you certainly can help assist them in the administration of their nitroglycerin. This is what nitroglycerin looks like in the tablet form. It also comes in a spray form, but you can notice here that the container is a dark brown glass, and that's because when nitroglycerin comes in contact with sunlight, it deteriorates it. The glass container here has a very tight lid to keep oxygen and air out of there, because when exposed to the normal environment, that also degrades the nitroglycerin as well. If the blood pressure is good enough, in other words, greater than 90 or greater than 100 millimeters of mercury, if the systolic is that good, then they may be a candidate for nitroglycerin. You do want to ask all patients, male and female, whether or not they've had a drug for erectile dysfunction, or whether or not they've had a drug like Viagra, Levitra, Cialis, those sort of things, within the last 48 to 72 hours. Erectile dysfunction drugs dilate vessels, and so does nitroglycerin. You've got to have authorization from medical control to administer this medication, but that authorization can be offline medical control like we discussed in the last chapter. You can give one dose of nitroglycerin under the tongue, and you can repeat that dose in 5 minutes as long as the patient is still having discomfort, as long as the patient's blood pressure is greater than 90, and as long as medical direction authorizes another dose. Now, most protocols, I know the state of Iowa protocol, would allow you to give the nitroglycerin up to 3 times. But you don't have to stop there. If you're still caring for the patient and you've given your third and final dose of nitroglycerin, if the patient's pain is still occurring, if their blood pressure is still above 90, there's no reason you can't give more nitroglycerin. You would just need medical direction to do that. Probably more important than the nitroglycerin is the administration of aspirin. If you think that a patient is having an acute coronary syndrome, one of the most important things that you can do is to quickly give them 2 to 4 baby aspirin and have them chew those up. So the indications for giving aspirin, the patient has to be having heart-related chest discomfort, they can't be allergic to aspirin, and they shouldn't have a history of asthma. The reason for that is that people in their 30s and 40s who have asthma may develop a condition called aspirin-induced asthma. So if they have asthma and you give them aspirin, it may precipitate an asthma attack, a really bad asthma attack. So if the patient is wheezing or has a history of asthma, they're really not a candidate for aspirin. That last bullet point really doesn't apply in your ability to administer aspirin. We have patients who certainly take an aspirin a day. We have patients who are on Coumadin or warfarin. They're on some sort of blood thinner. If they're having heart-related chest discomfort, it's because they have narrowed, partially or completely occluded coronary arteries, and aspirin would be the most important thing that you could do for them, regardless of them already taking blood thinners. You can give it as long as there's no other contraindications to aspirin, like active bleeding. They have to be able to swallow, and again, you could use offline medical direction. Most people use chewable aspirin, and the reason they use chewable aspirin is that with chewable aspirin, it's more palatable. An adult plain aspirin is very sour. For most people, that's disgusting, and if they were to chew it up, it may make them sick and vomit. Now, causes of cardiac conditions are heart problems, which can be caused by a lot of different disorders that not only affect the heart itself like a heart attack, but affect the condition and function of the blood vessels as well. Coronary artery disease, or CAD, is a condition that narrows or blocks the arteries of the heart. Coronary artery disease is the result of fatty deposits that build up on the inner walls of the arteries. And those, it's not just fat. It is fat, it's lipids, it's cholesterol, it's calcium. All these things build up this gruel or this paste on the inner walls of the arteries, and this buildup narrows the inner vessel diameter, which restricts blood flow. Now, when this occurs, certainly a thrombus or an occlusion of blood flow caused by the formation of a clot on the rough inner surface of the diseased artery could occur. An embolus is a blood clot that breaks free from somewhere else and travels and gets lodged in the system. So emboli can move to occlude flow of blood downstream in smaller arteries. The overall result of coronary artery disease, or narrowing of the coronary arteries, is a reduced blood supply to the heart. And that can cause an emergency and is the cause of the emergency in a majority of heart-related medical calls. Chest pain is most common symptom that you'll see in a person who has a reduced blood supply to the muscle. The heart certainly is a muscle that begins to beat from the 5th week of conception all the way till you die. And as a muscle, it works, and there are times it works harder than others. But when the heart does begin to work harder than normal, it requires more blood, more of a blood supply to the tissue itself. And if it doesn't get that, like any muscle, it's going to cramp up and hurt. Now, an aneurysm is a weakened section of the arterial wall that begins to dilate or balloon out. Bursting of an aneurysm certainly can cause rapid life-threatening internal bleeding. So here's an example of an aneurysm, and of course the vessel below it shows what would happen if that aneurysm would burst. An electrical malfunction of the heart may occur whenever the heart's electrical conduction system isn't working properly. The heart has the unique capability of automaticity. Automaticity is the ability for each individual cell of the heart to generate its own electrical impulse. So I could chop the heart up into a billion pieces, and each piece would beat on its own. Dysrhythmias include very slow heart rates that could be called bradycardia, very fast heart rates greater than 100, tachycardia, and rhythms that may be present when there is no pulse, like ventricular fibrillation or pulseless V-tach or pulseless electrical activity or asystole. So the different types of acute coronary syndromes include angina pectoris and acute myocardial infarction. Now, congestive heart failure occurs when the heart becomes enlarged as a result of chronic hypertension and other problems, and this enlarged heart becomes flabby and soft and is unable to contract very hard. Angina is chest pain that is caused by insufficient blood supply to the heart muscle itself. It's due to narrowed coronary arteries. The pain usually comes on when the need for oxygen increases, such as exertion or stress, and ends or stops when you stop the activity and rest. Now, an acute myocardial infarction, acute means sudden, myo means muscle, cardial means heart. So an acute myocardial infarction is a sudden heart-related infarction. Infarction means death of tissue from lack of oxygen. Coronary artery disease is usually the underlying reason for an acute myocardial infarction. And here's an example of the area of infarct. Let's say that this vessel was occluded by a thrombus or a blood clot that formed in there as a result of coronary artery disease. The death or damage of the muscle starts on the inside and works its way to the outside. When it's completed, which takes about 6 hours, all this tissue is dead. And dead tissue does not conduct electricity, nor does it contract. Congestive heart failure occurs when there's inadequate pumping of the heart. It often leads to excessive fluid buildup in the lungs or the body. So patients with congestive heart failure, if the left side of their heart fails, they develop acute pulmonary edema. If the right side of their heart fails, they develop pedal edema, or swelling of the ankles and the legs. Congestive heart failure may be brought on by a diseased heart, may be brought on by diseased heart valves, chronic hypertension or high blood pressure, or chronic obstructive pulmonary disease like emphysema or chronic bronchitis. Congestive heart failure can be a complication of a heart attack as well. In other words, the first thing you have is a major heart attack with a good portion of your heart dying, and then that dead portion of the heart doesn't work as a pump, and you go into congestive failure. So the progression might be that the patient sustains an acute myocardial infarction and part of the left ventricle dies. The heart gets its blood supply. The left ventricle gets its blood supply from the lungs. So if the left ventricle fails because of an MI, blood is going to back up into the pulmonary circulation and back up into the lungs, causing a acute pulmonary edema. Signs and symptoms of congestive failure include tachycardia, rapid heart rates greater than 100, shortness of breath, cyanosis. Blood pressures may be normal or elevated. They'll be sweaty, and they'll have the presence of pulmonary edema, which you can hear when you listen to the lungs, or you may see it in the form of frothy blood-tinged sputum. The patient may be anxious because of hypoxia, may have pedal edema indicating right heart failure, may have engorged pulsating neck veins or jugular vein distension, which is a sign of right heart failure, and their liver may be enlarged or their spleen may be enlarged, both causing the abdomen to be distended. This is a very late finding in congestive heart failure. All right, so that ends part 1